Glasgow Coma Scale. The Glasgow Coma Scale provides a practical method for assessment of impairment of conscious level in response to defined stimuli. The Glasgow Coma Scale is an integral part of clinical practice and research across the world. The experience gained since it was first described in 1974 has advanced the assessment of the scale through the development of a modern structured approach with improved accuracy, reliability, and communication in its use. The scale was described in 1974 by Graham Teasdale and Brian Jennett, professors of neurosurgery at the University of Glasgow's Institute of Neurological Sciences, as a way to communicate about the level of consciousness of patients with an acute brain injury. Components of GCS. Eyes. Verbal. Motor. There are 4 criteria for eyes. 5 for verbal. 6 for motor score. When assessing a patient, do 4 steps. Check, observe, stimulate, and rate. The preliminary check is used to identify any factors that might interfere with your assessment. It is important to identify local factors such as a hearing impairment that could cause a lack of capacity to respond. Following these preliminary check, we observe the patient noting any spontaneous behaviors in any of the 3 components of the scale. The patient is rated in each component by matching findings with the corresponding criterion. For each component, the top criterion is a normal response, whilst the lowest criterion is no response. If the patient's eyes open spontaneously, spontaneous is recorded. Remember, there may be local factors such as swelling that prevent eye opening. If spontaneous opening is not demonstrated, a verbal stimulus is used by introducing yourself clearly, and requesting eye opening, if necessary by shouting. If the patient opened their eyes, record to sound. If the patient does not open their eyes when you speak to them, a physical peripheral stimulus is then applied. Stimulation starts at a low level by pressing on the nail tip, and is applied with increasing intensity for up to 10 seconds, until the patient demonstrates a response, or under maximum stimulus has been applied. If the patient opens their eyes, record to pressure. If they do not open their eyes, record as none. If there are local factors such as swelling, interfering with opening, record eyes not testable. To assess the verbal response, ask the patient to tell you their name, where they are, and what month it is. If they answer correctly, record orientated. If during conversation, the patient is able to speak in phrases or sentences but is unable to give the correct answers to these questions about orientation, record confused. If they do not talk sensibly but utter single words, record words. If the patient moans and groans with no recognizable words, record sounds. If the patient makes no sound at all, then record none. Remember, speechlessness may result from factors other than depressed consciousness. For example, the presence of an endotracheal tube. In these cases, record verbal not testable. To assess the motor component of the coma scale, first ask the patient to perform a 2-step action, by asking them to grasp and release your fingers, with their hand or opening their mouth and sticking out their tongue. If the patient does this, record obeys commands. If the person can't move their arms, example, because of a spinal injury, you should ask them to open their mouth, and stick out their tongue. In a patient who does not obey commands, a peripheral stimulus alone is inadequate. To assess the motor component of the coma scale, and an additional central stimulus is needed. This is first applied by the trapezius pinch. To perform this, place your hand over the patient's shoulder, and press your fingers into the muscle above the shoulder blade. Apply pressure with increasing intensity for up to 10 seconds, until you are sure that the response you observe is the patient's best response. The second location for central stimulus is the supraorbital notch. Apply the stimulus if there has been no localizing response to the trapezius pinch. This stimulus is applied by placing a hand on the forehead with the thumb over the upper rim of the orbit. Feel for the notch in the supraorbital margin. Apply pressure with increasing intensity for up to 10 seconds, until you observe the patient's best response. The patient should not be rated as having an absence of response until the maximum stimulus has been applied. This stimulus should not be used on patients with facial injuries adjacent to the supraorbital notch. If the patient moves their hand above their clavicle, or collarbone, in an attempt to move the stimulus away, record localizes. If their upper limb does not reach above the clavicle, but does flex, then they are either normally or abnormally flexing. In clinical practice, the assessment of these non-localizing responses is based on a combination of both peripheral and central stimulus. In normal flexion, the elbow bends and the arm moves rapidly away from the body and from the stimulus. In abnormal flexion, the elbow bends slowly and the arm comes across the body. If in doubt, record normal flexion. If the patient extends their elbows, rather than flexing, then record extension. A patient who makes no response is recorded as none. If they are paralyzed by other factors, such as paralysis by drugs, record, motor not testable. If different responses are exhibited between limbs, on right and left sides, record the better side response as the best index of overall responsiveness. The response of the worst side may reflect focal brain damage or local injury. The results are reported as the Glasgow Coma score. As an example, a person's score might be GCS 12, E3V4 M5. Alternatively, if a patient was intubated, their score could be GCS E2, VNT, M3. Here is the time to test yourself.